second highest prevalence in the world. These are our learning objectives. This is a diagram which is showing that Pakistan has got a genotype 3 prevalence. This graph is showing that the 5 countries of the world, that is China, India, Egypt, Pakistan, Indonesia, are having 52% of the global burden of hepatitis C, and definitely as they are very densely populated countries, so therefore they are having the largest number of patients in these 5 countries. This is the geographical distribution of hepatitis C in Pakistan, and you can see the prevalence in our province was reported 5%. This was done in way back 2010. This is the geographical distribution of hepatitis C, and it is showing the frequency, and there are some areas where this is more than 10%, and some areas where we don't have any readings, like Gilgit in Parta and some other parts of Balochistan. This is the hepatitis C viral structure. It has got an envelope glycoprotein, and its size is around 50 to 65 nanomicrons. It's a single-stranded positive sense RNA virus. Flaviviridae is the family. There is no RNA polymerase proof readings, which leads to a lot of heterogeneous viral population. Its half-life is 2.7 hours. Nearly 1 trillion of the virus are produced per day, and there is a genetical diversity. Out of these, in our country, it is genotype 3, and it has been said that these genotypes, they are basically age related. The oldest one is genotype 6, and from where most of the virus has arrived. It's an old virus. It's not a new virus. It has been here for centuries. Risk factors: injecting drug uses, blood products which are not being screened. Prior to 90s, nobody was screening for hepatitis C, but now it is mandatory to screen for hepatitis C. Still, there are some not good centers which are doing these unhygienic and unscientific activities. Unsafe injection use, traditional practices, tattooing and body piercing with the unsterilized equipment is another risk factor. Needle stick injuries to healthcare provider. Vertical transmission, patient unfortunately are on hemodialysis. And sexually transmission, especially a man who is having sex with men. This is the life cycle, and you can see a viron which gets entered. The site is the CD81 and SRB1. From their receptor, it gets internalized into the cytoplasm, where it is being encoded. And when uncoating of this viron occurs, it results in translation and the processing, which happens in endoplasmic reticulum. RNA replication is being there. Then from this, these RNA is being replicated, and the assembly is done in the Golgi apparatus, and from where the Golgi apparatus, a mature viron is released. The lower segment is showing a structure of genome, and you can see there are C, E1 and E2, which are the structural protein of the viron, and then P7, NS2, NS3, NS5A, NS5B. These are the non-structural proteins of this virus. Life cycle: viral polyproteins. From its translation, you can see again there are 3 structure proteins, C, E1 and E2, and then there are 7 non-structure proteins. These structure proteins and non-structure proteins, they undergo translation, resulting in a single viral polyprotein, and it is being released. Why the non-structure proteins are important? Because these are the therapeutic target for treatment, which we are going to talk. So, protease inhibitor, NS3-4A protease inhibitor, it assists the downstream cleavage of viral particle and ability to cleave and inactivate host proteins. So that add in antiviral activity. So if we have got any drug which is blocking this protease, the antiviral activity will not be blocked. NS5B RNA dependent RNA polymerase facilitate viral replication by copying a positive strand RNA into negative strand RNA. And it's a template for a more viral RNA genome. So you block it there, and there will be no viral replication. NS5B lacks proofreadings. Now, NS5A is a replicase. It assists in viral replication and viral assembly. So block it at the replicase and there will be no viral replication and virus. Potential therapeutic targets in hepatitis C replication cycle. You can see this could be entry and P7 inhibitors. It could be internal ribosome entry site inhibitor. It could be fusion inhibitors. The three which are available are protein inhibitors, protease inhibitors, and NS5B, which is polymerase inhibitor, and NS5A, which is a cleavage inhibitors. And this is has been highlighted as well. This is learning objectives. The natural history and disease burden. Long-term natural history of hepatitis C infection is highly variable. Chronic infection is also accompanied by extra hepatic manifestation, cryoglobulinemia, renal diseases, diabetes, cardiovascular diseases, porphyria cutaneous tarda, lichen planus, lymphoproliferative disorders, non-specific symptoms such as fatigue, nausea, abdominal pain, weight loss. Increased risk of liver failure and hepatocellular carcinoma is there. Overall estimated that annual risk for the liver failure is 2.9%, for hepatocellular carcinoma is 3.2%, and liver related diseases is 2.7% in patients with advanced fibrosis. The lower pattern is showing uh, normal liver, then fibrosis, initial stiffness, and then fibrosis leading to cirrhosis, and then hepatocellular carcinoma. We have to identify 170 million people who are living worldwide with the disease, and only less than 15% are knowing that they have got the disease. You do the screening. When you screen them, you test them, you find the patient, you counsel them, you assess them for the stage of disease, offer them a treatment, and hope for the. So parental injectable drug user, nasal cocaine, transfusions, needle stick injury to our healthcare provider, tattooing, body piercing, manicures, household items, and hemodialysis. Sexual multiple partner, some unfortunate event in the life, HIV positive, use of a commercial sexual worker having a rectal contact, or men having sex with men. Perinatal with high viral load, and mother with HIV positive. This was the United States guideline by CDC and the United States Force for this task force, and this recommendation can be used. They are good recommendations. They have used for them, but we can also use them in incarcerated people, IV drug abusers, occupational hazards. So it's a good slide to have an insight how to do or devise a screening program for your own self. So there are questions that should everybody who have got persistently elevated ALT should get hepatitis C virus. I usually do it. Person who has recognized occupational exposure, healthcare provider, should everybody, every healthcare provider has to be screened? Well, not necessarily. And HIV positive, traditional practice, and things like that. Hepatitis C is usually diagnosed by a screening test, is serological test, it's an antibody, and when you find an antibody, it's better to virological PCR. Confirmation is done by detecting HCV RNA. All persons with positive anti-HCV antibody test, they must undergo a PCR. It can also quantify the virus. It can also find out the genes, and before starting treatment, we have to do a PCR to find out which patient we are going to treat. These are the different molecular testing machines. We are in Pakistan mostly. We have got Cobos or Abbott, and they are being used with different laboratories of our country. Determination of genotype, you do a PCR, then you do a determination of genotype, and InnoGenetics, a Belgian company, is doing this, and we can use this another treatment. But there are we have got medications who have got pan-genotypic. So in this case, most of the time in hepatitis C, potentially eliminates the need for genotyping. But in specialized cases, we have to do a genotype. If you have to assess fibrosis or disease severity, you have got liver biopsy, serum biological markers, and fibroscan. Liver biopsy is the gold standard. It is invasive, painful, it can cause pneumothorax, it can cause bleeding, and the only test it can accurately assess severity of inflammation and degree of fibrosis. Non-invasive tests, there are fibro test which combines 5 markers such as alpha-2 macroglobulin, haptoglobulin, GGT, total bilirubin, apolipoprotein A. FibroSpec2 which combines 3 markers, that is alpha-2 macroglobulin, hyaluronic acid, tissue inhibitors of metalloproteases 1. APRI, and this is AST2 platelet ratios. France fibrosis index which uses age, platelet count, GGT and cholesterol. FIB4 which combines 4 markers, platelets, ALT, AST and age. Transient elastography is available in our hospital and it is being used. It's an expensive investigation and the machinery is not easily available everywhere. Now we are going to talk about the treatment. And these are our learning objectives. The aim of treatment of hepatitis C is a cure. When we compare it with our two friends, hepatitis B virus and HIV virus, we find that it hasn't got a stable genome as compared to hepatitis B, which has got a cccDNA, and HIV, which has got provirus. So the elimination is very difficult in these patients, but in hepatitis C, we can get a cure. SVR is the sustained virological response. At the end of the treatment, PCR is negative, and after 3 months of the treatment, PCR is negative. It is said that the patient has got an SVR. And you can see that different therapy, interferon monotherapy, interferon with ribavirin, pegylated interferon, ribavirin, and DAs, and they are being used to achieve SVR. SVR is durable. It improves the quality of life of your patient. It leads to improving the histology of the liver, and the clinical benefit is that the risk of liver-related death is decreased. The chances of patient developing a clinical state of a decompensated liver disease is decreased. The development of esophageal varices risk is decreased, and similarly the risk of developing hepatocellular carcinoma is decreased. Even in those patients who have got advanced fibrosis, if we achieve SVR, the chances of all-cause mortality or rival-related mortality or transplant and the chances of hepatocellular carcinoma has been decreased. This is the same showing that if a patient have got marked fibrosis and you treat them, you achieve SVR, the survival is better in these patients. Initially, we have to use pegylated interferon. Before pegylated interferon, we were using conventional interferon with ribavirin, and the SVR with pegylated interferon ranges around 30 to 50%. Then came the time of directly acting antivirals, and these are the drugs which are acting on as a protease inhibitor, NS5A inhibitors, and NS5B inhibitors. The drug which is having previr at the end is a protease inhibitor such as grazoprevir, paritaprevir, semiprevir, voxeloprevir, glicaprevir. And those drugs which are ending as SVIR are NS5A inhibitors such as diclostavir, elbasavir, ledispravir, ombitavir, velpatasvir, and pebrentasvir. And those which are acting as buvir are NS5B inhibitors, and we have got sofosbuvir and desabuvir. Protease inhibitors have got high potency, limited genotypic coverage, and low barrier to resistance. NS5A inhibitors, they have got high potency, they have got multi-genotypic coverage, and low barrier to resistance. NS5B, they have got intermediate potency, pan-genotypic coverage, and high barrier to the resistance. So ribavirin protease inhibitor such as bezoprevir or semipravir or voxilaprevir, NS5A replication complex inhibitor, declustravir, elbesvir, ledispravir, ombitasvir, velpatasvir, and peprentasvir. NS5B nucleotide is sofosbuvir, and non-nucleotide is desaprovir. And the drugs which are highlighted, these are easily available in Pakistan. So protease inhibitor, polymerase inhibitors, and NS5A inhibitors. This is the DAs which are available in 2020 for the treatment of our patients who are suffering with hepatitis C. Oral DA regimes guiding principle is that combine drugs from different class, protease inhibitor, polymerase inhibitor, and NS5A inhibitor. So multiple drugs combine to produce greater efficacy, and they reduces the risk of viral resistance. Indication for treatment, everybody should be treated. Priority, those are the people who have got significant fibrosis, patient with HIV co-infection, patient with hepatitis B virus infection, patient who have got an indication for liver transplant, patient of hepatitis C recurrence after liver transplant, patient with clinically significant extrahepatic manifestation, patient with debilitating fatigue, individual at risk of transmitting hepatitis C virus. Treatment is not recommended with limited life expectancy due to non-liver related comorbidities, but this is a difficult statement to say, and it has to be very individualized and with the consent of the patient and the attendants. Though these are the group of people who can transmit disease to others, such as active injection drug users, incarcerated people, men who have sex with men with high risk sexual practices, patients on long-term hemodialysis, HCV infected mother of childbearing age who wish to be pregnant. Treatment option available in Pakistan: patient who have got normal liver, treatment naive, SOF and VELPA for 12 weeks, SOF and DECLA for 12 weeks. Treatment experience, you combine with the ribavirin. In compensated cirrhosis, SOF and VELPA combined with ribavirin for 12 weeks, and you are giving DECLA, you can give it for 24 weeks. In patients who have got SOF treatment naive and treatment experience, you can continue with 24 weeks. Third group is the decompensated cirrhosis, and it's a difficult group. There are so many questions. We have to establish the stage of the disease, and there are side effects associated with the regime. They are not able to tolerate most of the time. So this group has to be given treatment after full explanation of the situation and the chances of the complication. At the end, this is the site from where you can look for the drug-drug interaction. This is important to know the drug-drug interaction